Hello, and welcome to Chronic Mental Health Illness, Part 3. My name is Winona, and I will be your instructor today. I want you to view this video through the lens of a nurse. Think about, what is this child diagnosed with? What do I see that supports this diagnosis? Try to come up with at least 2 nursing diagnoses and think of some nursing interventions. Think about short-term and long-term goals for this child. So go ahead and pause the slideshow and watch video 1. Stress is the body's natural defense system against predators and danger. It flushes the body with hormones to prepare the systems to evade or confront danger. This is known as the fight or flight mechanism. Long-term exposure to stress has been linked with mental illness. The core concept of stress-related disorders is stress. How did you do? If you chose acute stress disorders, this is an inappropriate nursing diagnosis. Symptoms are time limited up to 1 month with acute stress disorders. And I think this trauma was going on for a lot longer than that. What did you see that made you think this child had PTSD? Did you see flashbacks? Like when she reacted when she received the dress as a gift? Did you see relationship problems? Depression? How about complicated grieving? Did she display any inappropriate anger or self-destructiveness? I think so, especially when she broke the record player. Emotional distress was probably compounded by her foster parents putting her in a cold shower. I definitely saw self-blame when she felt bad because she wasn't able to take care of her little brother. So now that we know that this child has a trauma-related disorder, and we know that our goals are to start that psychological process of healing, and that she would be able to deal with her emotions appropriately, what can we do to help a child with this stress-related disorder? We can do primary nursing. Primary nursing is when you work 4 12-hour shifts, and then you have someone else that works 3 12-hour shifts that's opposite you. And each of you would take the same patient on the days they worked. That consistency would allow for both nurses to build a relationship with the patient, to have opportunities to use motivational interviewing, therapeutic interaction, active listening. Keep all promises. Do not make promises that you cannot keep. And if the patient does experience flashbacks, stay with them. What are your nursing interventions? Well, our goals are for the child to express anger appropriately and deal with emotions appropriately. But what can we do to facilitate that? Build a relationship. Primary nursing is going to help with that. Develop a safe atmosphere. Model adaptive behavior and give positive feedback. and listen to their story and give them permission to cry. Which scenario concerns you? An emotional problem exists if behavior manifestations are not age appropriate, deviate from cultural norms, or interfere with adaptive functioning. Neurotransmitters are chemicals that are responsible for your physical, emotional, and cognitive activity. A child's exposure to violence is a lifetime legacy that is manifested by neurotransmitter dysregulation. Children that are exposed to chronic stress in utero may have non-functioning adrenal glands by the age of 5. Some of these children have less adrenaline in their system than an 80-year-old by the age of 5. This can lead to mood disorders, learning disorders, ADHD, and more. Have you ever met an individual that does drugs and you just think, why? It's just messing up your life. Imagine if you had a significant event and felt nothing. The birth of your child was just another day. Your favorite video game that you've been working on for 6 months and you just beat. You know that feeling of like euphoria and happiness and on top of the world? You don't experience that. You look around and you notice that everyone around you seems to have this experience of joy and happiness, but you feel numb. You want to know why kids and adults with neurotransmitter disorders take drugs? Because they take that drug and for the first time in their life, they feel good. They feel euphoria, that top of the world feeling that no one can take away. What wouldn't you do to feel that again? So the next time you take care of someone who is a drug abuser, I want you to pause and look at that patient holistically before you pass judgment. What is the key to stress-related treatment modalities? It's not therapy. Nutrition helps. Medication is good. The key to treating stress-related disorders are nurturing relationships. And you, the nurse, may be the first nurturing relationship that child has experienced. We're going to continue and talk about neurodevelopmental disorders. We're going to concentrate on intellectual disorders, autism spectrum disorders, attention deficit hyperactivity disorders, and Tourette's disorders. When you watch this video, ask yourself, what is this child diagnosed with? What assessments support your diagnosis? What would be some appropriate nursing interventions? And what would the short-term and long-term goals be? Please pause the slideshow and watch video 2. So the child had Down syndrome with the diagnosis that the child has is intellectual developmental disorder. Usually the onset is prior to age 18 and is characterized by impairments measured in intellectual performance and adaptive skills across multiple domains: work, home, school. Intellectual developmental disorder is characterized by impairments measured in intellectual performance and adaptive skills across multiple domains. What domains? Both clinical assessment of IQ and adaptive functioning needed for daily life. The degree of severity of intellectual disability may be measured by the client's IQ level. 4 levels have been delineated: mild, moderate, severe, and profound. The levels are differentiated between the ability of the child to perform self-care, cognitive and educational abilities, social and communication capabilities, and psychomotor capabilities. Specific behavioral manifestations and ability associated with each of these 4 levels of severity can be found in your text. What are some other reasons that a child may have intellectual developmental disorder? Well, severe neglect, impoverished environments, so poor socioeconomic status, and other severe mental disorders such as severe autism spectrum disorder. Nurses should assess and focus on each client's strengths and individual abilities. Include the family. Knowledge regarding the level of independence and the performance of self-care activities is essential to the development of an adequate plan for the provision of nursing care. You may be asked, what can I expect? What's the future of my child going to look like? Will my child have children? Will they walk, talk, go to school? Ask yourself, are you qualified to answer these questions? And if you do, you want to focus on hope. Oh, look at that smile. You hit the jackpot. You'll never find any other child that is going to love as hard as your child is going to love, that's going to want hugs and kisses, and is going to light up the room. Be careful what you say. Your words as a nurse hold power, and what you say may influence the way these parents interact with their child for the rest of their life. What strengths and abilities do you focus on? Well, I know if this patient was an inpatient I was taking care of, I would focus on, is the child safe? Do they want to harm themselves or others? Parents will ask you, will they be able to care for themselves? Will they be able to talk? Will they be able to function at the level of their peers? Will they make friends? Goals for treatment of a child with intellectual disability should focus on preventing injury, improving self-care, and to meet communication needs. Interventions should include creating a safe environment for the child, preventing physical aggression, and acting out behaviors. Identifying aspects of self-care that are within the child's capabilities, and fulfilling needs until communication patterns are established. A more comprehensive plan of care can be found in your text. It is essential that family members or primary caregivers participate in the ongoing care of the client with intellectual developmental disability. They need to receive information regarding the scope of the condition, realistic expectations and client potentials, methods for modifying behavior as required, and community resources from which they might seek assistance and support. What do you think the nurse should focus on? I would focus on community resources because I would want to make sure that this family is supported when they're discharged. Please pause the slideshow and watch video 3. The content is testable. I want you to look for what was considered normal for a person with autism. And think about when you take care of a patient that has autism, how will you adapt your assessments and patient teaching? I would like you to watch this video and focus on how did the individual in the video describe normal. Video 4, I'd like you to watch 3 minutes and 15 seconds of this video. The essential feature of Tourette's is the presence of multiple motor tics and at least one vocal tic. Onset may be as early as 2, but occurs most commonly around age 6 or 7. And that's because around the age of 6 or 7, the child's behavior is outside the cultural and social norms. This disorder is more common in boys than girls. Tics can be simple or complex. They can be motor or vocal, and they are all involuntary. They cannot be ignored and voluntarily stopped. Remember, safety is a nurse's #1 priority. Do these patients suffer from depression? And if left untreated, what can that lead to? What do we want? We want for the child to be safe, to not harm themselves or others. We want them to be able to interact with staff and peers in an appropriate manner. When I say demonstrating self-control by managing tic behavior, we know that they cannot control this behavior. But remember when the gentleman was walking down the street and he used his backpack to as a cushion so that he would not slam his head into the cement. So we can help them to modify their behavior so that they can stay safe. We want them to follow the rules and have a healthy self-esteem, because we know when patients have a healthy self-esteem, they are more likely to comply with treatment and less likely to engage in risky behaviors. So when we implement interventions, we are going to make sure that the patient stays safe. We're going to encourage interpersonal interaction. And sometimes, nurses are really good people to practice with because we are positive, we want what's best for our patients, and maybe this is one of the first interactions they've had where someone is patient with them and is willing to engage with them. And when we do that, we're going to help them to feel worthy, to have a positive self-esteem, to feel like they matter. Education, family therapy, counseling will be instrumental in helping families and patients with Tourette's disorder. Now we're going to move on to disruptive behavior disorders. Okay, so you guys are going to pause the slideshow and you are going to watch Beth. And I believe that you will remember Beth for a long time. With conduct disorder, there is a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. Physical aggression is common, and peer relationships are disturbed. This is one of the most frequent reasons that children and adolescents are referred for psychiatric intervention. Prevalence estimates range from 2 to 10%, and the prevalence rises from childhood to adolescence. And it is more common in males than females. And there is a higher male predominance among those with the child onset subtype. A number of comorbidities are common with conduct disorder, including ADHD, mood disorders, learning disorders, and substance use disorders. Oppositional defiant disorder. These kids are sassy, but they typically do not want to hurt you. Which of these characteristics would you see in younger children and which in older children? We want patients with ODD to accept, comply, and interact appropriately. We want these children to accept responsibility for his or her part in the problems they create. We want them to comply with treatment, and we would like them to interact with others in an appropriate manner. Anxiety is not a problem unless it does not correspond with a person's developmental level or interferes with the person's social, academic, or occupational functioning. And notice I said developmental level, not age. If you have a patient that has intellectual developmental disability and it is severe, then it would be appropriate, it may be appropriate for that individual to suffer from separation anxiety. So onset as early as preschool. So why do we start worrying about it in preschool? Because they have to go to school, don't they? They have to function away from their attachment figure for several hours a day so that they can learn and get ready to start their long career of school, stuck there till 12th grade. So what do we want? We want the child to function away from their attachment figure. And anxiety can be hereditary. So it's a little more complex if you have a mother with anxiety and a child with anxiety. These case studies, we're going to go over them. I would like to encourage you to pause the slideshow and to get your text and to go through these and then see how you did. And that will help you when you're preparing for the exam, and you'll learn a little bit more. So we're going to start with Frankie. What's wrong with Frankie? And what clues do you see that support your diagnosis? What about Eric Erickson? What stage is he in? How did you do? Frankie is a 9-year-old boy with attention deficit disorder. The key concept of attention deficit disorder is hyperactivity and impulsiveness. And the hyperactivity and impulsiveness needs to be a pattern that the child's experienced for at least 6 months. What about neurotransmitters? If you have not watched the videos on neurotransmitters, I would encourage you to pause and go look at those videos. They are interesting and they will help you with your exam. Studies indicate that children with ADHD, when compared to general population, have low levels of dopamine, norepinephrine, and serotonin. Well, so what? Why is this important to Frankie? Because norepinephrine influences the brain's ability to analyze and reason and sustain thought and attention. And low levels of serotonin will affect how impulsive he is, because it's correlated with the disinhibition and impulsivity. So what are 3 priority nursing diagnoses for Frankie? Risk for energy, mercy help us. Risk for injury, because he's accident prone. And safety is one of the nurse's #1 priorities. So because he's hyperactive and impulsive, he is at an increased risk for an injury. He's going to be the patient where you're raising up the bed to do an assessment and he decides to jump off. Social interaction, has that been affected? Well, this is when you need to think about his psychosocial tasks. So according to Eric Erickson, he's in the task of industry versus inferiority. And if he's successful, then he's going to develop self-confidence. But if he fails, he is going to feel inferior. These children have squirrel syndrome. They're easily distracted and do not have an attention span. We want them to be able to stay independent and have the ability to perform at the level of their peers, and this allows them to fulfill the psychosocial goal of industry, or at least the age of Frankie. Low self-esteem related to dysfunctional family systems and negative feedback is not a priority at this time. So what are our goals for Frankie? We want him to not be harmed and not harm other people. We would like him to have a peer group, participate in therapy, accomplish his psychosocial goals. And in school, We would like him to be able to complete assigned tasks independently with minimum assistance. That's going to help with his self-esteem. And that's going to help with his self-confidence. Notice that these medications are seen as stimulants. Usually we're going to start these medications when the children are in school because that's where you're going to see the biggest impact on the patient's education experience. Now I gave you an example here. When you are going over patient education and reviewing medications with Frankie's caregivers, you need to make sure that they know the side effects of the medication. Make sure they can do a teach back with that. And then make sure they understand the directions, why they're giving the medication, when they're giving it, and how much they're giving. Because the directions might not make sense to them. So if you receive medication and the directions are give 40 milligrams during the day and 20 milligrams at night, they may not understand why it's being ordered that way, and that's going to decrease compliance. But if you tell them that they're getting 40 milligrams during the day and 20 milligrams at night because that will help Frankie to sleep, whoa, okay, now you have parent buy-in. I want Frankie to sleep. If they hear the side effect of growth reduction and they think, I'm not going to give this to him, I don't want him to be short, but you give them the information, give him a drug holiday, maybe in the summer, and that can minimize the growth reduction so he's able to grow normally. Or the doctor might say you can hold the medication on weekends. Then that's going to help me to be compliant. So now we're going to move on to Peter. So Peter, looks like he has some issues. What do you think Peter has? What do you see? What clues have you found? What facts support your diagnosis? Did you get it right? Conduct disorder with polysubstance abuse. So remember, in conduct disorder, these patients can get physically aggressive. They may want to hurt you without remorse. Look at the correlated comorbidities: tobacco, liquor, drug use, sexual promiscuity. What do all of these have in common? All of them give a temporary feeling of pleasure or happiness. Do you think these patients would benefit from being diagnosed earlier and placed on medication? They've given up academically, so low achievers, that's what he's done. Low self-esteem, so he's going to have that tough guy act. But he could have anxiety and depression. And if left untreated, what does untreated depression lead to? So he has conduct disorder, so he's violating the rights of others. could be physically aggressive, doesn't feel guilty, and on top of that, he's impulsive and hyperactive. So this young man has a hard road ahead of him, and he's going to need a lot of support. Patient safety is always a nurse's #1 concern. When you are caring for a patient with conduct disorder, know your exits. Do not ever let your patient get between you and the door. We want to work on his self-esteem because we know that patients that have a positive self-esteem are more likely to participate in therapy and less likely to participate in negative behaviors. So the diagnosis of defensive coping related to self-esteem and dysfunctional family systems, this is a big one because if we can modify this behavior, that's going to affect his ability and willingness to express anger in an appropriate manner. And that could change his life. What are our goals? We would like this child to interact with us in an acceptable manner. So we need to make sure that we are using controlled, deliberate therapeutic engagement strategies and not frustrating him. And then long term, maybe he needs to participate in a structured peer group situation so he can learn to deal with challenging and frustrating tasks and situations while he's interacting with his peers. Family therapy with the possibility of parents with antisocial personality disorders, severe psychopathy, alcoholism, substance abuse users, and resource-poor hurting individuals may complicate your patient's strive for wellness. Because his parents may be hurting individuals that need to assist their child on their journey to wellness when they themselves are not well. Not all of your parents will fit in this category, but some of them will. We want to coach the parents in techniques to manage aggression, and that's by modeling that behavior. Encourage the parents to allow their child to express their anger in an appropriate manner, and teach them adaptive coping strategies you would like them to utilize when they're dealing with their child when they have feelings of anger or aggression. And also, this would be outpatient long-term, but we would like the parents to be able to assist their child in accepting responsibility for their behavior in a blameless environment. It's not your fault, it's not good or bad, it just is. We're going to move on to Seth. What do you think Seth has? And what information will support your diagnosis? The key concept to autism spectrum disorder, I want you to remember that it is a group of syndromes characterized by a wide range of communication and impairment restrictions and repetitive behaviors. Almost half of these individuals with ASD have average or above average intelligence. So this is a range of disorders. You can have severe ASD where you have an intellectual developmental disability disorder, or you can be a genius and Bill Gates rich. So it is a whole spectrum. How do we know that they have autism spectrum disorder? They have an impairment in social interaction, communication and imaginative activity, and they have restricted activities and interests. you may see these patients stimming. So impairments in social interactions. What if you have an infant that doesn't like to be held? Do you think that may affect the parent's ability to bond with that infant? So we really need to make sure that these children get into early childhood services, sometimes when they're still infants. They also need to get into skill building groups. Some of them will have special abilities. They'll be able to read in preschool. Some of the patients with ASD will have patterns of play that are so restrictive and repetitive that they aren't able to interact with their peers. You may see patients with autism spectrum disorder for other things like surgery or in a clinic for a well child visit. And if you notice that the parents are interacting with the child, but their communication is only something that they are able to understand, and you start talking to them, that should raise some red flags that makes you ask questions like, do they have repetitive behaviors? Have you ever noticed them stimming? Remember the video? Starts and stops are hard for individuals that have autism spectrum disorder, and sometimes even minor changes in their environment can elicit agitation and irritability if they have the severe form of autism spectrum disorder. So their diet can be restricted, and constipation is often associated with these individuals. They may have a toy that is inappropriate for their age. A 15-year-old that likes to watch a spinning top. Nursing diagnoses. Remember, client safety is always a priority nursing intervention. We want to work on that social interaction because we want them to be able to succeed in the psychosocial development and the tasks that are associated with that. And if we don't work on their impaired social interaction, then this can affect them their whole lives. If they also have problems with communication, then this child may not be able to complete the psychosocial tasks until we're able to find a way to communicate with them. And it can also lead to isolation because they may not be able to find a life partner and have close peer relationships. What are our goals? We don't want them to hurt themselves or others. We would like them to start developing an alternate behavior when they have a trigger if it leads to harm to others or themselves. And we would like the child to stop harming themselves. There are several more short and long-term goals that go with autism spectrum disorder because it is a spectrum from severe to Bill Gates Smart and Rich. You can go ahead and look at your text to review some of those, but there's quite a few of them, and some of them just exceed the limits of this presentation. So education. Remember, we're going to be referring these patients so that they can get early childhood intervention. Try to teach the parents to anticipate the child's needs, to have an attachment object. It's usually a good idea to get these children into like daycare or preschool so they can experience safe adults that are able to care for them and demonstrate warmth and acceptance. Tell the parents to go ahead and use those diversional activities and to start to identify triggers so that the child can thrive in the home. We can't control triggers everywhere, but usually in the home we can make some adaptations so that these children can be content there. Thank you for your time and attention.